Good. My name is Diane Thompson, and I'm a physician at Columbia University Medical Center. I'm an assistant professor there, and the medical director of the inpatient rehab unit, and the medical director of the outpatient cardiopulmonary unit. And I'm going to go over there in a second. I also practice lifestyle medicine. That's it. I just wanted to get a sense of who's in the room. So we have nurses, physicians, so nurse.
I'm a nurse practitioner.
Awesome. What about in the back there? Okay, and I was a nurse practitioner in my former life. And physician? Okay. Okay, awesome. Welcome everyone. And you? All right, welcome. And I know Dr. Wendy said I don't have to ask her. All right, so today I'm actually going to be talking about using lifestyle medicine to prevent, treat, and reverse many of the diseases and disabilities that we're seeing in our patients. I was very fortunate to come across lifestyle medicine a few years ago because on my rehab unit I had patients coming in with stroke and heart attacks, and their lives are no longer the same. And when I realized is that we could have prevented a lot of these. And I wanted to find something that was evidence-based, especially because I'm in academic medicine. If I go to Columbia with some kind of medical model, they want to make sure that there's evidence to support it. And I was able to implement a lot of these changes for my patient. And I'm very happy with the result, and I really feel that I should share this with other people because there is this cheap, very inexpensive way, safe way, effective way of helping our patients. The only thing is many of us make the mistake of saying to a patient, eat less and exercise, and the studies show it doesn't work. So there are better ways, and I wanted to come and share that today. I have nothing to disclose. What I hope to cover, and I have 58 slides in 25 minutes, and I'm not going to run over in Dr. Wendy's time. So I'm going to be running through these, but the slides will be available if you want them. I'm going to be defining lifestyle medicine and look at some of the other models that are out there. Why? Why do we need to do it, and why do we need it now? The more important part of my talk, I think, though, is the strategies, some of the strategies that are out there to help your patients design a healthier lifestyle, because I think people struggle with that. You tell the patients, there's lots of information out there. Patients know sometimes what to do. They go on the internet, there are information out there. But what comes from the information to them actually executing and consistently doing what they need to do, they're two different things. So there's some more information to that. So what is lifestyle medicine? This is from the ACLM website. And what's key here is that it's therapeutic, it's evidence-based, and these are intervention that it's not an afterthought like we do now with preventative medicine. This is actually the core of what you're doing with your patients. What's important is that this patient is going to be very active in the care. It's going to involve behavior change, which is something patients aren't used to. So how is this different, you may ask, from what you're currently doing? So most of us were trained in the conventional practice of medicine. Today I work with residents and medical students, and unfortunately many of them are still trained this way. The emphasis is on making the diagnosis. So a patient comes in with the symptoms, you listen to the signs and symptoms, right? You take a good history, you do a physical exam, and you think about what may be going on, and then you make some recommendations. And it's usually a prescription for a medicine or some procedure. So this patient is very passive. They tell you, you figure it out, you tell them what to do, and they leave your office with this thing that they should go to the pharmacy and get. It is the medical model as a physician or the health provider, the nurse practitioner, you are the one who's telling the patients what to do. And as I mentioned, medications are the primary therapy of this. Most times we don't take into consideration what's going on at home. With lifestyle medicine, it's different in that you are making the emphasis on promoting behavior change. It is evidence-based. Patient is now the active partner in this care. This doesn't work if they don't do what they need to do. So you're going to provide the education, the guide, the support, the resources, but that patient has to do in order for this to work. And medication is actually seen as an adjunct. Now this is not, we're not used to this, right? Lifestyle, the therapeutic lifestyle measures are seen as the primary thing, and yes, your patient may need to take medicine, but that's not the primary focus. And if we want success, we have to look at the home, the community, the support system, because all of that is going to play a role. There are other models of care. As you mentioned, you're a naturopathic, yes. Functional medicine, by the way, is another one that's pretty close. If you look at it, they look at a lot of the root cause, so there's a lot that's similar to lifestyle medicine. So what are the target behaviors in lifestyle medicine? Well, we're looking at their nutrition, we're looking at their activity, how much sleep they get. I struggle with sleep. I learned how to be a poor sleeper when I went to medical school. The entire auditorium of medical students will be up all night. I see you nodding because I know you know this. We'll be up all night studying, and then we go to class to take an exam with no sleep. I now know that this is horrible. Like, we do it as medical providers. How do we expect our patients to do better, right? It also involves stress reduction. We know this is so important with mental health. We've heard in the news recently a couple of suicides in the States of people that we all know very well. And it also looks at fostering good social network, because this is so important. So what are the benefits? Lifestyle medicine isn't expensive. It's inexpensive to implement, and it is not a surgical procedure where you have to go to school for years to learn it. The information is there. Basically, this is really one of the research-driven practices that's inexpensive, good for your patient, doesn't have side effects. So why aren't we all doing it? There are kind of downsides to it, right? So our current system isn't set up for lifestyle medicine. It is so much easier for someone to come in, the blood pressure is high, okay, I'm going to give you a prescription, go get this pill, goodbye, and I move to the next patient. It's easier for me to see more patients if I do that than for me to sit down and figure out, what are you eating, how are you preparing this? That takes time, right? Insurance doesn't pay for counseling right now. We hope to change that. It also takes creativity. What works for one person doesn't work for the other, so you're going to have to spend time doing that. Another thing is that physicians will have to walk the talk, right? I have a good friend, she's in Texas. She calls me up all the time. She said, I have these patients, they're so obese, they have so many chronic diseases, people have stroke, they have diabetes. I really want to teach them lifestyle medicine. You know what the problem is? She is morbidly obese, so she won't talk to them. Right? So if you're doing the thing, if you haven't gotten yourself together, right, you're going to think, who am I to go tell this patient? So physicians kind of keep it to themselves. There's lack of training. I didn't learn lifestyle medicine the way I should have learned it in medical school. It was sort of an afterthought in terms of prevention. A lot of it was on treatment. Once the disease occurred, and managing the disease. There's a lack of training in behavior change. That's really important. That's a big part of lifestyle medicine. To get someone to do what you want them to do, you have to be able to assess where they are in the model of behavior change, and you have to, and you know, depending on where they are, you offer them resources. And if you don't know this, you'll be pushing up against a patient who really doesn't want to do what you want them to do, and you don't know why you're not getting ahead. And as I said, there's resistance from patients and physicians. I gave a talk at a church in Harlem a couple of weeks ago, and there was a patient there, and I was talking about the fact that lifestyle medicine can reverse chronic diseases. There are people who've had diabetes and high blood pressure for years, and it's been reversed. And the woman got up and she said, you know, if you had told me this 2 years ago, I would have said to you, you're a liar. Well, what happened to her, she was following this primary care doctor for 20 years. This is a woman who was diagnosed with high blood pressure and diabetes. What am I supposed to do here? Remind me later. Okay. So she was diagnosed with high blood pressure and diabetes. Wonderful patient. She came to appointments every few months. The doctor would give her her prescription. She took her medication. She did this for 20 years. That primary care doctor retired, and the new doctor came in, thank goodness, with new views. And she said, oh, instead of me just prescribing your meds, let's sit down and talk about what you're eating, when you're eating, what you're cooking, what's in your home. And the woman was angry. She was like, what's foolishness is this, right? For 20 years, I've been doing fine. What is this? Well, she sat down with her, and I will tell you, 2 years later, she's no longer taking medicine for diabetes or high blood pressure. This woman thought she was doing the right things, but as you talk to patients, you learn about the things they're doing, and sometimes it's a small tweak, but nobody ever told them this, so they just continue. So sometimes you will get patients that are resistant to this. This is new for them. And as I said, for physicians, this work. So in terms of the history of lifestyle medicine, this statement from Thomas Edison, this is really a person ahead of his time because it is so true. Until we figured out as physicians and other healthcare providers that nutrition is integral in healing your patients, until we figure that out, we are just reactive and figuring out things after they occur and kind of managing that. In fact, it's Michael Greger who often says, it's sort of like you go in a room, the tap is overflowing, and you go with your mop and you're just mopping up. That's what we're doing. What we need to do is to turn off the sink, right? So turn off the faucet. So in terms of lifestyle medicine, we have these guys that started out years ago. When they did, they will tell you that people thought they were crazy, right? What are you talking about? Nutrition, right? It's medicine that we do. It's surgery that we do. And a lot of them talk about the fact that they were ridiculed back then when they first started talking about using nutrition and exercise and stress reduction and all of that. But now we're learning better. The ACLM, so I put this here in case anyone is interested in this. This is the American College of Lifestyle Medicine. They were organized in 2004, and we now have the lifestyle medicine boards. We have a little over 200 certified physicians worldwide. I'm actually one of the certified physicians, and in October there'll be another board exam. So what do we know so far? We know what lifestyle medicine is. We know the pros and cons. We know the behaviors we target and some of the players and the history of it. Why lifestyle medicine? Well, chronic diseases. It's interesting if you go to the WHO website. If you look back like in the 70s and 80s, it talked about communicable diseases. That was the main thing. Then it talked about, some of these chronic diseases, but they weren't that important. And then each year you read, you see, they keep talking about chronic diseases. This is now a problem. Now what they tell you is that it is the public health challenge of the 21st century. They need to figure out a way to handle this because most of your patients that are disabled, most of the deaths, they come from chronic diseases that are very preventable. And actually, the CDC says if we as providers could control diet, the inactivity, and smoking, we would actually prevent 80% of heart disease and stroke, 80% of type 2 diabetes, and 40% of cancer. I look at the patients who come to my rehab unit, those that used to work before, they were providers, they were professionals, they were fathers, husbands, whatever, and now they're patients, they're disabled, their life is no longer the same. And I think to myself, my goodness, we had a chance to prevent these things. This is someone who did not now have to live this life the way it is. And it's not just in America, globally, we see a rise in these same kind of chronic diseases. Diabetes is a big one, and globally, diabetes is increasing everywhere if we continue on this trajectory. I couldn't find too much for the Caribbean, but way back in 2002, we started seeing that some of the risk factors that cause a lot of death in the Caribbean were again these players, high blood pressure, obesity, right? These are things we can do something about. And talking about obesity, we see a continued rise in obesity from year to year in men as well as women, and wait, children are also involved. In fact, diabetes, when we used to say We thought it was adult onset diabetes. We don't say that anymore because we have children as young as 12-year-old who are coming in with type 2 diabetes. And it's all because of the way they eat, their inactivity, basically lifestyle. And what we do know though is that we can make a difference. The other thing is that with disability, they just run hand in hand. It's like this wheel because these people, they tend to have the diabetes, the high blood pressure, all of those things that put them at risk for heart disease and stroke and all of that. They become a bit disabled. Now they can't move, so now they're even more overweight. So it's such a challenge when I have those patients. So in terms of the evidence to support lifestyle medicine, there's so many. I just picked some of the highlights and I'm sharing them here. You can read them on your own. But we have seen research. I'm talking about research that are in peer-reviewed journal. This is not voodoo medicine, real research that shows that lifestyle medicine and lifestyle changes can actually compete with many of the medications that we write for our patients when it comes to controlling their diabetes and their cholesterol and their blood pressure. So we know this, so again, why are we not doing this? Ornish even did a study that showed that low-fat plant diet could reverse prostate cancer in men in 3 months. I mean, there's so much out there that shows the validity of this, but as providers, we're not doing it, and I feel that we're doing our patients a disservice. The other thing that we know is that if you look around the world at the blue zones, the blue zones are the 5 places in the world where you have people who live the longest, healthiest lives. We're talking about the most centenarians, and these are people who are 100, 102, and they're driving to work or walking to whatever. They're not in a wheelchair, they're doing well. And so people wanted to know, what is it that they're doing? What is it that they're doing that these people are able to survive so long and so healthy? And what they found is that family and social interaction is important, but other things like how they eat, the amount of foods they eat, they tend not to overeat, and they do a lot of plant-based foods. They have constant activity. So your patient doesn't have to go to a gym 3 times a week, but to be very active, physically active. And this is what they found common among all these sites. So what we know that chronic disease is a global epidemic. It can lead to death and disability. We know that lifestyle medicine is actually, there's again, a ton of research shows that it can prevent, treat, and reverse diseases. And we also know that we, as providers, are not using it as much as we should. So what are some of the strategies to help design healthy lifestyles for your patient? Because so lifestyle medicine, I always say, it's simple, but it's not easy, right? Because if it was easy, everybody would be healthy, would be normal weight, would be active. It's not easy. There are many things that play a role. It's hormone, it's your community, it's a support system. There's so much that goes into this. So telling patients to eat less and exercise will not be a thing we do anymore because they're not going to listen to that. So the first thing though we need to do is what I say, physician heal thyself, right? If we're going to go out there and preach lifestyle medicine, we may want to think that, okay, I may need to apply this to my own life. Because again, the studies show that if a physician is not exercising, he or she is less likely to tell a patient to exercise. When a physician is overweight, that person is less likely to tell their overweight patient to lose weight. So if our own lifestyle is preventing us from being the good doctors and providers that we are, then we probably need to first look at ourselves and start implementing some of these. The other thing is a lack of knowledge. And I'm going to share at the end, there will be resources where you can learn about lifestyle medicine. Some of them are for free, so I highly recommend that you take a look. So design thinking is the way that I've found to be very effective to work with my patients to help them with their lifestyles. And what is design thinking? We use this in technology. It's great to use in health. It's a creative way to look at individualized health. Look at the problems your patient is having and help them to sort through it. So I work for Columbia University Medical Center. It's under the umbrella of New York Presbyterian Hospital. And they have like a lot of hospitals throughout New York. But the sister hospital is at Cornell. I also have privileges at Cornell. Two different patient populations. My patients at Columbia, they are poor, they don't speak English, most of them. They don't have good insurance, poor health literacy. Many of them have chronic diseases. My patients at Cornell are very affluent. That is a very affluent neighborhood. They have a lot of resources. They're more likely to go to the gym. They're more likely to eat well. If I am going to approach the same problem with these two people, I cannot use the same techniques, right? So that's what design thinking allows you to do. Again, the steps would be to empathize. You have to know what's going on with your patient. Meet them where they are. Then you have to figure out what their needs are. And from there, come up with ideas. And remember, your patient is the active part of this care. So you come up with ideas, you come up with what you're going to try, and you iterate it. So they're going to try it, whatever doesn't work, you come back to the drawing board and you make changes. And you keep testing and improving until you find what works. So, for example, how do you empathize? You want to assess their knowledge. You want to know, are they ready for change? Because, you know, I have a guy, for example, in my cardiopulmonary rehab. He has COPD, can barely breathe, he still smokes 2 cigarettes a day. He is not ready for change. He told me, he said, I smoked 2 packs a day for years, I'm down to 2, I'm happy with that. No matter what I do to him, he's not going to change. So I keep supporting him, I offer him information, but if I write him a prescription for a patch, he's probably not going to take it. So you really have to know where your patient is, what they eat, how they eat, who cooks for them, and so forth. So really take a good assessment of what's going on. Empower your patients. More than likely, this is like their 10th time of trying to lose weight. And each time they try, they fail. And many times, by the time they come to you, they figure they're going to fail again anyway. So they'll only give you half an effort. So you really want to empower them. You want to help them to make that mindset shift. You want them to be an active participant. And it's okay to tell them that failure is not unusual. So when it happens, and it's not if, when it happens, they'll quickly bounce back. They don't spend a whole lot of time, you know, having a pity party because you've already warned them. You want to educate them. You'd be surprised the misinformation that people walk around with. When I start to talk with people, there was one guy who loved what he ate. No matter what I told him, he wasn't going to stop. However, what we figured out was that he was eating for like 4 people. So he was willing to decrease his portion size. Now when he lost about 20 pounds without really trying, that's when he came back and he said, okay, what do you want me to do? Because I see this thing work. So sometimes just taking that information and educating that patient will make a huge difference. You want to look at their environment and optimize it. Patients, by the way, don't like for you to take away things, but it's okay to replace things. So you make suggestion like, well, if you like sodas, many times it's the fizz that they like. So you say, okay, well, maybe we can try the seltzer water. You can put some lemon in there, or people will put watermelon to give it a little flavor. I've been able to take people off of sodas doing things like that. So you figure out what they like and you make some replacements for them. The other thing, again, is looking at their social environment, right? So there was a gentleman who came to me. I was talking to him, so I always do a diet recall. That's going to be really important. Do like a 3-day diet recall. Sometimes a 7 day is really great. And because they'll tell you, no, I don't eat this, I don't eat that, I do fine. And then when they write it down, that's when you really find out what they're eating. And so he thought he was doing everything fine, but he was morbidly obese and had just had a stroke. So finally, when I wasn't getting anywhere, I said, can you have your wife come in? So his wife wasn't my patient, but I needed to know because she was doing the cooking. And when I found out, we figured out where the problem was. It's how she was preparing the meal. And there was a lot of fried things that he didn't seem to know were fried. So I spoke with him, with her present, and she made the changes in the kitchen. And when he dropped the weight, and by the way, when she came back, because she was morbidly obese also, she dropped the weight, and suddenly, now we had them all as a team working on board. The other thing, and this is going to be really important, is to actually prescribe the thing. So like I said in the past, we normally would say, go exercise. And patients may start, they may do something, they may not even know how much to do. You really need to write a prescription. I actually have a prescription pad in my office for exercise and nutrition separate. And I write it out and I sign it and I ask the patient about it and I put it in my notes. So they know I'm serious. It's just like I'm writing a pill. The format for exercise is usually TAF, and interestingly is the reverse of fat. And the thing with this is, it's also, you think of it as a positive or negative prescription, right? So eat more would be a positive, drink less off is a negative. So a sample of this TAF would be 1 apple with lunch every day for a week, or a half a cup cooked spinach with dinner 3 times a week. Like I've met someone who said, I don't eat vegetables, I don't like it. We figured out a couple of things he would eat, and then I wrote the prescription because I wanted him to eat it, and he was able to stick with that. The same thing with exercise, you need a prescription. So this is what the American Heart Association let us know for exercise recommendation. I tell patients what it is, but I know this is not for all my patients. So I will sit with them and look at where they are. If you've never, ever exercised before, I don't expect you to do 30 minutes a day, 5 days a week. It may just be 5 minutes today or 5 minutes 3 times a week. So FIT is how you would write an exercise prescription. It's the frequency, intensity, type, and the time. And here's a sample of how you would write one. Begin walking at a moderate pace. You would explain to them what that is for 30 minutes, 5 days a week for a month. And then you reassess them like you would if you wrote a prescription for your medication. The studies show that when you write prescriptions, patients will more likely follow that. The other 2 things that I do, so I will do healthy groups. There are many of them out there. Some of them, unfortunately, are expensive. But what I've found is that if I can get a patient in a group, they do very well. What patients do, when you as physicians tell them what to do, often they don't relate to it because they think you're different, you know more, and all of that. But if Betty across the table, who was morbidly obese, figured out how to drop 30 pounds, then suddenly, okay, maybe I can do this thing. So if you can get them in a group, a lot of times that group dynamic will do half the work for you. The other thing was also shared medical appointments. So they actually were doing shared medical appointments where 10 people with diabetes would come to the one appointment. You'd have your medical assistant and your nutritionist, and you'd see them all at once. And what they found, so when this first started, many of the docs who were doing it, it was really a lucrative thing. It was a way to make money where you have several people at once. What they found was these patients did better for the same reason. They're listening to each other. Oh, I went walking yesterday, and then suddenly there's that healthy competition where, oh, I didn't go walking, maybe I should. And you don't have to tell them, they just learn it among themselves. So these turn out to be beneficial for the patients, even though that's not necessarily what they started out for. The other thing which we often don't do is to teach our patients about lapse and relapse. They're going to happen. And you want to prepare your patients that when they happen, what to do. So I lapsed yesterday. I was on a flight. I think I ate 3 packs of chips. I don't normally even eat chips, but I was there for 4 hours and they handed them and I ate them. But I'm not going to do that today. My lapse isn't going to become a relapse. Think of times your patients will lapse. Certain holidays, Christmas, different times where they eat a lot of meals. You know that meal is going to be a lapse. It's okay. What you don't want is for them to take home a whole lot of leftovers and they spend the whole week continuing to eat the same way. You don't want them to go back to where they were. And so you want to, again, give them the contingency plan. Sometimes you have a health coach in the office and you have that person. In case something goes wrong, give that person a call. Let them know what to do. Get them a buddy. There's a big thing now of friend power over willpower. Willpower actually will go away. It doesn't work. If you pass, they've shown the studies. You pass the chocolate, the cake, all the things. At a certain point at the end of the day, your willpower is gone and you're going to do something bad. Friend power, though, is where you have that accountability buddy. And they found that it's very effective and helpful. So, Chronic diseases, leading cause of death and disability. We know that the rates are going up every